Next up, we've got Dr. Louise Oliver, who works as an NHS GP and privately as a functional breathing practitioner and therapeutic life coach, and teaches others to breathe as nature intended. Dr. Oliver will be talking to us about medically unexplained symptoms that may be related to the individual's underlying breathing efficiency.
Can you hear me okay? Fantastic. Brilliant. So let me just thank you for your time. I'm going to be talking about medically unexplained symptoms, which is actually a descriptive term. And what I want to actually just open your mind to, have we truly excluded all the biological causes for their symptoms? So in my NHS role, I work as a GP. Privately, I work as a breathing practitioner and life coach. And I can't diagnose or prescribe in my breathing role. I truly believe health and well-being is like a jigsaw puzzle of many pieces, and that's a blog with zero cost resources, which I share with my patients. My conflict of interest is I am passionate that we all breathe efficiently over a 24-hour period, and I get paid to help people to return to breathe as nature intended. One piece on that jigsaw puzzle is how we breathe matters. Now, it may be actually quite a new concept to some people, so I divide it into three. First of all, an awareness that we've come into the world as a baby that's beautifully been designed to breathe as nature intended. And how we breathe impacts health and well-being, but unfortunately we're not necessarily living as biologically programmed, so we're not necessarily breathing as biologically programmed. So we can breathe efficiently, inefficiently, or anywhere in between. And you might not believe me, but we can change how we breathe. So in medicine, we like to divide things up, don't we? So in sleep medicine, we like to, if we're inefficiently breathing, we call that sleep disordered breathing. So that could be anywhere from sleeping with the mouth open, snoring, increased resistance to the air coming in and out, which we can term upper airways resistance syndrome, or obstructive sleep apnea, where we're actually narrowing or blocking the airway significantly. In respiratory medicine, when we're breathing inefficiently, we call it breathing pattern disorder, or the old-fashioned term dysfunctional breathing. But we are one person. We are not an awake Louise and an asleep Louise. And actually, how we breathe whilst awake does have some bearing on how we breathe when we're asleep. And I prefer to think about it as more of a 24-hour breathing pattern. But first of all, I think everybody, whether we're a health professional or a patient, I think everybody needs to understand a really simplistic explanation of the autonomic nervous system. And I'm sorry if I'm teaching you to suck eggs, but this is how I explain it to patients. I think the human body is totally and utterly amazing. I am here and I'm not paying any attention to my blood pressure, my pulse, my temperature control, my pupil size, my saliva, my bowel, bladder, genitals, etc. That is all under the control of the autonomic nervous system. We can simply divide it into two. So the sympathetic nervous system, a lot of patients, as soon as you describe this, they know this, the fight, flight, freeze system. And it's not a bad system, it's great. It's helped us develop and cope with adversity. When the body feels a threat, opportunity or challenge, the dial on this turns up, and all these processes are put more into short-term survival. The body can get inflamed in this state, which is a good thing when I've got pneumonia or I've got a sprained ankle. And how do we breathe in this system? So somebody accidentally let go of their dog and there was no conscious control. I just breathe like this. So it was big, it was fast, it was open mouth. I held my breath on the inhale, it was upper chest. And that was a good thing because my amygdala, the part in my brain that controls emotions, is looking at my breathing centre and sees me breathe like that, and then turns the dial up on the fight, flight, freeze system, and then pushes everything towards short-term survival, which is properly appropriate when I've got a dog about to bite me. But I think we need to talk not about how often we've got the fight, flight on. Let's talk about this other beautiful side. Rest and digest, feed and breed, relaxation response. In this system, when the body feels safe, the body can go into repair and recover mode. All those processes are pushed into long-term survival, so we can now have libido, ability to reproduce, digest a meal, sleep, and feel relaxed. The vagus nerve has a role on this side and has the ability to turn down that excess inflammation when we don't need it anymore. And I knew when the dog owner got hold of the dog and I was fine, I needed to breathe the opposite. So I shut my mouth and I breathed. My amygdala sees me breathe like that. Oh, she's safe now. And turns the dial down on the sympathetic and turns the dial up on the parasympathetic relaxation response. So when I hit my perimenopause and I started to breathe like this, my dial on my fight flight's up when I'm asleep. That's not the way it should be. Luckily, I recognised I wasn't breathing efficiently, and now I breathe like this when I'm asleep. And that's why I'm passionate about what I do. So, two of my patients are really excited to talk to you in their own words today. So this lady is someone who'd had been thoroughly investigated by two of my secondary care colleagues and couldn't find a cause for her symptoms. Having had several miserable years of suffering a wide variety of symptoms, pins and needles or limbs, left side of face, weight loss, gut issues, a wide selection of tests, no diagnosis was made. I'd given up hope. I went back to the doctors exhausted when I was only getting 3 hours sleep a night. I saw Dr. Oliver, who suggested I took part in a breathing seminar, as the problems I was having could be connected by me not breathing correctly. Initially, I thought, how bizarre, what a strange thing to suggest, but was so desperate I accepted her offer of a free place. By doing the seminar, it became very apparent I had a problem with my breathing. My comfortable breath hold time was only 3.5 seconds. Even though I didn't feel breathless, I followed the easy exercises, and within a short time, I was having between 6 and 8 hours sleep a night, and eventually my other symptoms ceased. Thank you. My second patient is a complex patient, and this is my letter to the sleep clinic. Dear sleep clinic, please could you investigate this patient for sleep disordered breathing? Risk factors are chronic fatigue syndrome, large neck size, raised BMI, pre-diabetes, perimenopausal, and taking opiates for persistent pain. The patient does not feel she has sleep disordered breathing. However, managing her symptoms and conditions is complex. And if she has untreated, undiagnosed sleep disordered breathing, it will hamper her progress. Thank you. And this was her sleep study. So the apnea-hypopnea index is how often she blocks her airway or significantly narrows it enough. And she was doing that 8 times an hour. So 8 times an hour, she's generating a fight-flight response to open her airway. That's a problem. But actually, that supposedly only classes as mild in our... I don't want to be doing that at all. And actually, she was snoring 22% of the time, she didn't realise. And this is what's happened. I was diagnosed with chronic fatigue syndrome 10 years ago. I've been bed or housebound, needing a wheelchair with severe post-exertional malaise, and my brain scrambled. My physical and mental health has declined, my world becomes small, and affected my friends and family too. I thought it was my fault I couldn't get better, that I hadn't tried hard enough, or that I must be doing pacing wrong. Dr. Oliver described solving fatigue as a jigsaw puzzle and suggested a sleep study. I was reluctant at first. I was very surprised to be diagnosed with sleep apnea, and after just one night on the CPAP machine, I woke up feeling alert, refreshed and energised, mind truly blown. I'm continuing to improve, and I'm now completely pain-free, mind blown again. I've come off all opiate-based medication. I'm working my way off the rest. I hope to be just on HRT soon. I was also at serious risk of losing my job. However, I am now able to plan an extended phase return. Thank you. So I'd like to remind you what NICE say about obstructive sleep apnea-hypopnea syndrome. They say we should assess people for it if they've got 2 or more of the following features: unrefreshing sleep, waking headaches, unexplained excessive sleepiness, tiredness or fatigue, nocturia. I don't pass urine anymore now, since I've corrected my breathing. It's the most unexpected and most welcome side effect of improving your breathing. I see it in others as well. Choking during sleep, sleep fragmentation or insomnia, and cognitive impairment, cognitive dysfunction or memory impairment, but also snoring and witness apneas. So unless we're asking our patients, do you snore? Do you stop breathing during sleep? You will not know if they've got 2 or more of those. So if you learn nothing more from this talk, please just start asking. You might need to signpost it because patients think you're a bit weird. But you just say, I'm just asking a question, it might seem slightly unusual. Do you snore? Do you stop breathing during sleep? And just watch what happens. If it's like me, my experience has been you see a hidden epidemic of sleep disordered breathing. NICE also remind us that all these conditions have a higher chance of obstructive sleep apnea, hypopnea syndrome. Some of them you may have guessed. For me, hypothyroidism was a real surprise, actually. I didn't know that. And you could argue with moderate and severe asthma, you could argue that every single person who's under a secondary care respiratory physician should be screened for obstructive sleep apnea, possibly, or at least you've got to ask the question. In 1975, Dr. Lum, who was a respiratory consultant in Cambridge, he published this paper, and what he'd noticed was there was a group of patients that were going through either the chest clinic or the cardiology clinic or both. They were being told there was nothing wrong with them, but they had a common group of symptoms. And I think looking at this list, I think a lot of these symptoms are common in perimenopause, PMT, but particularly the unexplained medical symptoms patients. And this is what he found. We probably see at least one of these patients a week. The type of breathing is utterly characteristic, virtually diagnostic, and seldom recorded in the notes. The size of the case folder is a frequent pointer to the diagnosis. He worked with his physiotherapist who helped them to convert to a slow diaphragmatic breathing pattern, and a significant amount of the patients, their symptoms resolved, and it was uncommon to find a patient who did not experience marked improvement. I cried when I read this paper. It's on the internet, it's freely available. I cried. I thought, it's nearly 50 years. Like, why didn't I know this when I graduated in 1998? How many patients could I have helped? All those patients who sat in front of me going, hungry for air. They're not anxious. And they didn't respond to my antidepressants because I had the wrong diagnosis. They were over-breathing. He received some criticism on this paper because he focused on carbon dioxide actual levels in the blood, and not everybody who overbreathes. I don't use the term hyperventilation, I use the term overbreathing because hyperventilation has a motion tag to it. Not every person who overbreathes has low carbon dioxide level because the body always wants to go back to homeostasis. So what is functional breathing? So functional breathing is, breathing's really complicated. You know, without breathing, none of us, even the best free divers, don't last longer than an hour holding their breath. So it is the ultimate foundation of life. And it's complicated. Our body does everything to keep us alive. So there's 3 dimensions of breathing. So if you just remember, breathe light, breathe low, breathe slow. There's a lot of talk about slow diaphragmatic breathing, which is absolutely correct. If we use the correct biomechanics, so at rest, you're generally going to use 80% of your work should generally be done by the diaphragm, that main breathing muscle under your lungs. If we breathe slowly, it's great for mental health and for our autonomic nervous system. But what I found when I started experimenting on patients when I was fitting contraceptive coils is I put someone in a profound parasympathetic relaxation response, breathing in and out of the nose, slowly using the diaphragm at 6 breaths per minute. Whereas when I tried it on other patients, I nearly brought on a panic attack. And why is that? Because there's a 3rd dimension that we're not researching. There's a 3rd dimension we're not discussing. The biochemical dimension is about overbreathing. So are we breathing in excess of metabolic requirements? And that's to do with our tolerance to our waste products. So carbon dioxide is a waste gas, but it's what drives the next breath. So we breathe in, we breathe out. It's your tolerance to carbon dioxide that forces the next breath. Some of our patients are so intolerant, they've probably not even finished their exhale before the drive to take the next breath comes in. And if you've been taught the oxygen dissociation curve, carbon dioxide is what helps release oxygen. So if you're intolerant to it, you're not going to be getting your oxygen delivered to your tissues and your brain, etc. But it's complicated to research. So But essentially what I do is I re-establish 24-hour nasal breathing and do a lot of work in improving carbon dioxide tolerance. I can only scratch the surface today in the time I've been given. So I just wanted to invite you to just experiment with your own breathing and just see what you felt. So it's an invitation, you don't have to join, but if you want to, one hand on chest, one hand on upper tummy. And if we can adopt a posture helpful for breathing. So imagine you've got a little string pulling you up at the back. Okay. And now just start to breathe in and out of the mouth and just watch what happens. So in and out of the mouth. Okay. So my breathing's gone heavier. I can actually hear you, actually. I can hear you now breathe. Okay, my upper hand is moving more, so I've gone higher and I've gone faster. Now close your mouth. Invitation to close your mouth if you can, seal your lips, and now start breathing in and out of your nose. I can hear you've gone lighter. For me, I've definitely gone lower and I've gone slower. So if you go light, low and slow, you turn up the dial on the parasympathetic, you turn the dial down on the sympathetic. Now, if you have that helpful posture, breathe in and out of your nose if you can, and then go forward and adopt a posture that's unhelpful and just notice what happens. So you might want to come back up and watch again. So for me, if I adopt a posture unhelpful for breathing, because I'm crumpling my diaphragm now, for me, I go upper chest, I breathe heavier, and I'm going faster. So again, that's turning that dial up on the sympathetic response. So we now understand posture. Hopefully posture is important, and so is nasal breathing. So how about if we have good posture, we're breathing in and out of the nose, but do a big breath through your nose. So yes. So we've gone heavy, but we've now gone upper chest and we've gone fast. And now how about breathing in through your nose slowly? So I've certainly gone slower and lower. And so there's so many important things to breathe in. But the main thing is, if somebody, I don't know if anybody here, you can put your hand up if you feel comfortable. Sometimes when you ask patients or yourself to breathe lighter and slower, what happens is you feel air hunger. So you feel suffocated. So that feeling of, I want to open my mouth, I'm not getting enough air, or I hope it's not a triggering term, feel suffocated. And that often is to do with carbon dioxide intolerance. And you can train someone. If someone's over-breathing, the only way you're going to correct that is to do breathing exercises so they can under-breathe. And that's essentially what I do. I've not got lots of time to go in what I do, but essentially in my programs, what I do is tell them not to hold their tummy in. You hold your tummy in, you get likely to freeze your diaphragm. It's a muscle, it gets weak. That was my problem, age 10. I work on opening the airway with correct tongue position, nasal breathing, strong muscles around the collapsible airway, and then significantly reduce over-breathing, so we're normalising the breathing volume and encouraging the correct biomechanics and breathing slowly. I believe everyone deserves to breathe as nature intended, whilst awake and asleep, including those who have medically unexplained symptoms. Thank you for your time. These are my social media handles, so if you're keen to learn more, please follow me, please share me. I'm fully aware I can't share my private services with my NHS patients, so on the menopause page, I've got 5 conversations that explain things in a bit more detail. If you're not born with ovaries or you're not menopausal, it's still relevant if you're an adult, just ignore the hormone bits. And the podcast information page has written information that gives more information. And I run a group program that is CPD certified. If you just want to learn more, join it. I've got a day retreat as well where I combine it with gut health, and I've got my individual program as well. And hopefully I've left 5 minutes for questions, I think. Yeah.
Do you have any questions for Dr. Oliver?
Hi, very interesting talk. I've struggled with this area for a number of years. Recently started mouth taping. I don't know what your views are on that. And it goes well for the first few hours, I reckon, when I'm asleep. But then my nose starts to close in, and I have to take it off halfway through the night. Is that something you've come across or have any tips on?
So basically, we've got to think about the 24-hour breathing pattern again. So basically, nose breathing is about health and well-being. Mouth breathing is about survival. Okay, We've got the ability to breathe through the mouth, so we can talk, and maybe at higher levels of intense exercise we revert to mouth breathing. But it's a survival mechanism. There is no health and well-being benefits from breathing through the mouth. If people understand about HRV, so heart rate variability, if you've got someone with their mouth open, you get it closed, you've got an instant improvement in HRV, as long as they can breathe through their nose. But the issue is as soon as you go from nose to mouth breathing, you've increased your breathing volume by at least 800 millilitres of air per minute. So just getting the mouth closed and doing nothing else, you've not corrected that over-breathing. So I ask all my clients to wear mouth tape, but I use a mouth tape that goes around the mouth with a big hole in it so they can still breathe through it. And at the beginning, the breathing volume is too high, they'll breathe through it. If you use a mouth tape that fully obstructs the airway, if you can't shift that breathing volume in and out of your nose, you'll mouth puff and you're actually going to splint your airway, make your sleep disorder breathing, obstructive sleep apnea worse. And the other thing, the more you mouth breathe, the more your nose gets congested. It's a use it and lose it organ. But I'm working on them doing breathing exercises in a day to improve their carbon dioxide tolerance, which helps open up the nose, helps reduce their breathing volume, and then using the myotape. And sometimes if people spread their nose like that, if people can feel they can get a bit more air in, then I ask them to use nasal strips as well. Because you've got to tell your body, I am going to be a nasal breather now. I've got to get air through there. So and the trouble is with social media, it's just about mouth tape. They're not talking about everything else. That's the issue. And I can't explain this in a 30-second reel.
Thank you very much. You're obviously a rare bird. Thank you very much. But how do we access people? So, I mean, the big thing is referring people to yoga or yoga for health.
Yeah.
So that's my first comment. And then you said something else, which is you breathe like this at night.
Yeah.
I'd love to breathe like this at night. I'm full of yoga, but I'm getting this thing about, so would the tape help?
Yeah. So again, it's I've got on my YouTube channel, I've got a how to assess your breathing efficiency video. It's 4 minutes long. You can share it with whoever, and it's working out how efficient. I don't know how you're taught, but at rest we don't need a lot of air. You know, we don't need to hear ourselves breathe. So if you're in a breathing class or a yoga class and it's we're encouraging over breathing. And breathing changes I haven't got time, but the breathing changes in the 3 hormonal transitions. And so I'd sort of think about how you're breathing in the day. And I've, if you look on that podcast information page, I've got a video with Dr. Indra, who's here on one of the stalls, and I've got three breathing exercises on there.
Time for one last question.
Michael Hutchinson, Chair of the British Council for Yoga Therapy.
Yep.
I listened to Dr. Claude Lum on the radio in 1988. And as a yoga therapist, I specialise in teaching people how to improve their breathing. And I have a book in print. And it's been great listening to you and hearing that now I imagine you've come at this from a very different direction. And there is so much we have in common. There are some things which are new to me, like tongue position. I just think that, you know, we need to get the message out. I tape my mouth at night and I've had no problems, but I appreciate other people may have problems. And certainly I'm very open to the criticisms you've made about the way some people teach breathing in yoga classes, which I wish I could put a stop to. Because, you know, certainly within the yoga profession, we need to get things straight. But I'm here to be a focus of authority in, you know, what yoga says about breathing. And so this is going back to, you know, what was said this morning by Dr. Michael Dixon, that some of us need to stand up and say, yes, I'm here. And it would be great to talk to you some more. Thank you.
There's a great book. So a yoga therapist, do you know Robin Rothenberg? She's wrote a book called Restoring Prana. And apparently she's gone back in the ancient texts, and breathing was very subtle how it used to be taught, I think. So I think it's just, And I think if we've got patients or people that are experiencing health and wellbeing issues, they're more likely to experience overbreathing. I think that's just what we've got to be a little bit careful with. Thank you very much.
Well, thank you very much, Dr. Oliver. And she was going through those breathing techniques and calming everyone, activating everyone's parasympathetic nervous system. I saw a wave of yawns spread across the audience.